Welcome to the Minor Consult, where I speak with leaders shaping our world in diverse ways. Today's episode continues our special focus on AI, exploring its potential to transform our health and discussing the ways that leaders are navigating its rapid evolution. Today, we'll be discussing the promise and pitfalls of AI in supporting patient mental health and the providers who deliver this vital care. I'm delighted to be joined by Dr. John Torous. John is the Director of Digital Psychiatry at Beth Israel Deaconess Medical Center, where he also serves as a staff psychiatrist and assistant professor at Harvard Medical School. John has dedicated the past decade of his research to understanding mobile and app-based mental health technology. He's editor-in-chief of the Society of Digital Psychiatry's Journal and has served as a member of the FDA Digital Health Advisory Committee. John, welcome to the Minor Consult. It's great to have you here today.
Excellent. Thank you so much for having me all the way across the country from Boston.
Well, it's great to have you. I hope everything's going well in Boston, and really excited about the work you're doing and our conversation today. John, you have a background in electrical engineering and computer science, as well as in psychiatry and informatics. What drew you to the mental health field, and what inspired you to make the connection between digital technology and psychiatry?
I think first I'll say it's a fascinating time for mental health and psychiatry, as we'll talk about. And I think I'm very fortunate to have the background I did coming into it. I actually did use electrical engineering and computer science across the Bay at UC Berkeley. And this was before AI was so hot, before mental health was so hot. But I think having gone to medical school at UC San Diego and then done residency here in Boston, perhaps the rigor as you're doing things in electrical engineering or programming, right, where things are very rigorous, you sometimes know where each electron is going as you're designing chips, and then you're working with patients, and of course it's incredibly complex. Everyone is a different individual with a story, but it's really hard to predict anything, to sometimes know what's happening. And I think it was just that discrepancy between my training in engineering and kind of being thrown into, say, emergency room consults and going, there is no formula to make the right decision. How do we proceed? And so it was a little bit of that fortunate background in seeing that there was a room to bring innovation and data into care was put me on a very fortunate track.
When we talk about AI, there's great promise to support mental health professionals in the care that they provide and to also expand access to mental health services, which we know is really challenging today. You and others have written about the potential for AI tools to help in many areas, such as detecting and diagnosing mental health conditions, personalizing treatments, and even helping therapy through chatbots. How do you think AI will transform, and how will we understand and provide care for mental health conditions given the AI revolution?
Yeah. And again, if 3 years ago we would not have been asking this question. So it almost tells you how far we've come in this field in 3 years, and it makes one wonder where we'll be in 10 years for it. But I think you outlined kind of three very interesting areas where it could have an impact. And if we just start with really just the detection of mental illnesses, right? We know that almost half of mental illnesses happen in youth, in younger people. And we know that early detection matters. If we treat people early, we can lead to better outcomes. We can really do a great job if we find out these illnesses early, especially say in ones like schizophrenia. Oftentimes people have these illnesses for years unnecessary suffering. And sometimes I explain to patients, it's almost like having inflammation in the brain, right? If we can put that fire out earlier, it's going to be better. We don't want it going. But it's really hard to detect these illnesses early in the community. We do not have a focus on prevention in mental health. As we'll get to, we don't have enough mental health providers. So it's hard to say we're going to move towards prevention of what we have. But if we can begin to use these different tools to help us understand people that may be at higher risk, people that maybe should get more screening, or we learn about what are new ways that illnesses manifest in this digital world. If youth are spending their time on the internet. I think the Pew data from 2024 said half of youth report being online constantly. So if we're not online as well and we're not learning from what's happening online, we're missing their life. We're not seeing what the full picture is. But you can imagine from that digital world and that ecosystem that younger people are on, and given that this is where half these illnesses are emerging for the first time, someone is already looking at that data, right? There are internet companies that likely have that data. There's social media companies that are using that data to understand patterns, let's just say for marketing to be broad. Imagine if we could use that data for health to transform it and say, hey, we're seeing different signals in what, say, John is doing. This is different in his pattern. This is when he should, say, connect to a psychiatrist at Stanford. This is when he should call someone in our clinic. So I think the detection will come quickly because there's such an unmet need for it, and there's such a personal case for patients, there's an efficacy case, there's a cost savings case. It's a hard one to beat. I think you brought up diagnosis as well, right?
Yes.
And diagnosis in psychiatry is tricky. I think sometimes people just think, well, you get to DSM, you have your checklist, and you kind of check off enough boxes, and you have a diagnosis. And it's never that simple. One is the DSM, those are kind of guidances for what to look for, but you really have to say, how is it impacting someone's life? How does it relate to different medical conditions? How do you roll other conditions? If it was as simple as checklists, we wouldn't need to have these diagnoses. It would be very easy, and AI would have done it already. But I think where it can actually be more useful, AI, is if we think about it, it's really hard to bring different types of data into psychiatry, into the exam room with my patients. If my patients have physical activity data from their Fitbit, and they have sleep data from their phone, maybe they have genetic data from somewhere else, I would love to know how that physical activity, that sleep data, that genetic data, and my clinical assessment help shape what the diagnosis could be. So I think the real potential for diagnosis is not a chatbot that interviews you and asks you some checklist questions and said, well, you could have this, this, and this. We don't need the menu approach. We've had the internet. We can do that already. There's websites with many checklists. What we really need is to bring in this more holistic, important information, and AI can help us sort through that. No psychiatrist has time to look through. We're not even trained in genetics, right? To let alone look through genetics or Fitbit activity or sleep activity. And that would be a wonderful way to really better understand what our patients are bringing to us, and can we use that to understand what the condition could be. And I think that leads to your third point of personalizing care. So we talked about we can detect illnesses earlier for prevention, have diagnoses based on more information that is going to be more accurate and precise. But for really giving people the right treatment is difficult. Sometimes when, say, prescribing antidepressants to people, I still don't know, right, in mid-2024, what is going to be the best antidepressant for my patient. And I do have to humbly tell them that we're going to have to do some trial and error, and I need you to report back to me, and we'll find the right one. And we have some clues of which ones people could go for, but I can't quite personalize treatment yet. And I think if we really had, right, of the millions of people, say, on these antidepressants or getting cognitive behavioral therapy, we really could learn from who those people are and what are those signals of people that respond well and respond early, to kind of replace a little bit of that trial and error. I think we do get it right, and I think it's not completely at random today, but my gosh, it could be a lot more efficient. And as we all have clinics that are struggling to keep up with demand, it would be nice to help people get the right treatment the first time.
Maybe spending just a few minutes on patient-facing apps, and you already talked about those. Of course, there are many out there today. There are likely to be many, many more in the very near future. And with our country in the midst of a mental health crisis, as you just described, and providers struggling to meet the demand for their services, there's a great need for this kind of support to expand access to care, and also to extend the care beyond the understandably episodic nature of the encounters between a patient and their psychiatrist or therapist. Your team at Beth Israel Deaconess has already done a lot of work evaluating countless existing consumer digital tools for mental health. So first, let's talk about what already exists independent of AI. What types of apps are there, and what are their limitations? And what are your predictions for the near term in terms of the future as AI gets more integrated into these apps?
Yeah, so there's a lot of, let's call it mental health or behavioral health apps out there. I think it was in 2017 with Dr. Laura Roberts, who chairs Stanford Psychiatry. She and I set out and we said, we're going to find out exactly how many mental behavioral apps are out there. And we started to count. And after about a couple hundred, we said, oh no, this is a lot. And we actually ended up having to estimate there were about 10,000 kind of wellness behavioral apps in 2017 across the Android and Apple Store. There's a huge amount of these things. And I think that number 10,000 that we again defined with Dr. Laura Roberts of Stanford has pretty much stuck pretty well. They come and go.
Yeah.
Sometimes they're almost like cargo ship containers. By the time you count them all, they've switched, they've changed, but there seems to be a vast amount of them. And I don't think anyone in the world has been able to fully keep track of them. I think even the FDA has said a lot of these are going to be outside of the scope of medicine. They said they're going to be in the wellness space. So I would say 99.99 rest in the wellness space.
Mm.
And almost right, just like you can go to the drugstore and there can be some kooky stuff on the shelf that says like not FDA cleared, but it promises to help with this, this, and this. A lot of these apps kind of make those same claims of what they'll do. So it's a little bit of a kind of buyer's beware. What are you getting and what are you seeing? But the backstory with that 10,000 number, we quickly realized it's going to be hard to look at every app. And is anyone who has apps on their phone knows they update all the time. But let's say, Lloyd, even you and I spend a year looking at all the apps. By the time we finish this epic journey, they've all changed.
Yes.
So with the American Psychiatric Association, we created an app evaluation framework that the American Psychiatric Association endorsed. And it really was an evidence-based education approach to say, if you're looking for an app, be it you're a patient, you're a family member, you're a clinician, find the ones that are safe first, right? Make sure that your data is protected. Then find the ones that are evidence-based, so risk-benefit. Then find the ones that are usable, because if the risk-benefit makes sense, you need to be able to tolerate or use it. And then look for the clinical utility. Why are you using it? What is it you're going to do? And we got good feedback based on that work of the American Psychiatric Association, but family members and patients, as well as psychiatrists and social workers and nurse practitioners, called us and said, I don't have time to go through your kind of pyramid. I'm busy. I have a patient office and we can't answer all these questions. So our team, with the support of the Argosy Foundation, created a website called mindapps.org, mindapps.org. It's completely non-commercial. It's free to access, thanks to Argosy Foundation. But we index about 600 mental health apps, as well as some pain apps, some headache apps. And we basically show you each app across 105 filters. That's too many filters. You don't need to know it. But you could then say, well, show me all the apps that are completely free, that have a privacy policy, that address depression, and do mindfulness, and are in Spanish. And I bet we'd come back and say, we have none indexed. We're sorry, Lloyd, you have to search again. But the idea is you can kind of create a query to find the app that you want with the price point, the evidence, the security, the engagement features.
Maybe moving the next step after the apps you described, of course, are the apps that depend upon and utilize generative AI technologies, such as chatbots. Can you describe the application today of chatbots in the field of psychiatry, and how effective are these tools, and what are the pitfalls that must be avoided in developing and using them?
Yeah, so our team, perhaps in about 2018, we actually did a review of all of the mental health chatbots, because there weren't that many in 2018.
Yeah.
It was actually feasible, and today that would be not feasible. But I think what happened between, right, say 2018 and now, as you said, generative AI came out. So chatbots had existed before, but they were rule-based chatbots, right? It's a kind of like if you were a kid, there was those choose your own adventure books, right? It says if you want to go into the haunted house, go to page 10. If you want to run away from the haunted house, go to page 30. So there were these rule-based chatbots that could kind of guide you through therapy, guide you through a diagnostic interview. And they were popular to some extent. Again, what popular means we can talk about later, but they were definitely commercially popular, but it really was just a rule-based chatbot. So the chatbot was a user interface, right? It was a nice way to guide you through it. The generative AI chatbots, right, are a whole different beast because they could say anything they want to say, right? They could say wonderfully helpful things. They could say horrible things. They could say dangerous things. And in some ways, I do think psychiatry and mental health is on the cusp and the leading edge of this innovation, but that also means in some cases we see when things don't go well first. And
Yes.
we had an example of it actually made national news. There was a chatbot that was helping with eating disorders, and it was endorsed by the National Association of Eating Disorders, NEDA, and the chatbot was released onto the internet. And what happened is it was partially a rule-based chatbot, but there was a little bit of generative AI for safety, right? Because if someone said that they're having a suicidal crisis, you want to respond in a way that would meet people's demand. But what happened is this little bit of generative AI that was embedded into this eating disorder chatbot somehow ended up saying some pretty unhelpful things to people about weight loss and dieting that just were not correct.
Mm.
And that chatbot clearly got taken off the internet by the National Association of Eating Disorders. But it really kind of raised a question of you can see harm can happen very quickly and unexpectedly. And I think the teams that released this chatbot had done their basic due diligence, and no one realized that the chatbot would start saying these things. And again, thankfully, it got taken down. So I think when you have generative AI, it can do all the exciting things we'll talk about, but it can also do the things you hope that never happen and do it. And we don't have great, I think we're learning how to gate those chatbots, right, and how to kind of put a protective screen up and say you cannot go into these spaces. But that may be impossible to guarantee, right?
Maybe, John, if you could use your crystal ball and even before the crystal ball, just focus on today. If we take the categories of prevention, diagnosis, and treatment of behavioral and mental health issues,
Yeah.
can you talk today about how are psychiatrists, other mental health care professionals such as yourself, today effectively and appropriately using digital health technologies in, well, first, even before psychiatrists and behavioral health professionals, how are people today using digital health technologies to prevent mental health disorders? Maybe you could talk some about the various apps that are out there focused on mindfulness, meditation, other things, and your assessment of how well they work and what people should think about if they're using them, and then move into diagnosis and treatment and how these apps are being used today, and maybe fast forward 3 years from now, how they can responsibly be used as mental and behavioral health professionals diagnose and treat mental and behavioral health conditions.
There's a relatively famous paper in our digital health space from 2019, which is the dinosaur age in digital health. We can barely remember 2019, but it showed in the American public people downloading a popular mental health app from consumer data. After about 10 days, 95% of people were not even opening that app again, right? It was just a decay curve that really quickly went to zero. And I think that showed us that just because you have access to these apps doesn't mean that you're always going to be using them and engaging with them. So I always tell patients, first, let's find something that is going to be something that's easy for you to use. And what's easy, say, for me to use is different than what you would like to use, Lloyd. And for other people listening. And it's hard, right? Behavior change is hard. Starting a new hobby is hard. Starting a new exercise regime is hard. Fitting an app into your life is not necessarily simple, even if we have a phone and we have access to these apps. But so I think for prevention, right, there's all these wonderful things people can do. But as we also know, if everyone would go to sleep on time, eat their vegetables, and exercise, we could do a lot of amazing things in healthcare beyond
Sure.
mental health. And there's really good data, right? Sleeping, eating, diet, exercise, those things are great for mental health. So we have to acknowledge just because we have the tools doesn't mean that it's easy for any of us to use them. But I think it begs the point of we really need clinicians to start integrating and using these tools, right? We know what is the best predictor if someone's going to, say, start a new exercise regimen, use lifestyle factors. Someone's going to go to therapy, take a medicine. It's their clinician, it's their doctor saying, this is important, you need to do it. And I'm going to follow up with you on it. We are going to see how it's going. It's that accountability. So it's not just saying, here's a handout of cool apps. You can look at some of them. It's taking it a little bit more in one step. But as you know, we don't really train our clinicians how to integrate technology yet. We're beginning to.
Right.
And I think at programs like Harvard and Stanford, I know we're making those steps, but I think it's not become a national phenomenon. And we're still graduating clinicians that go, well, I don't know how to talk about apps. I don't understand the risks and benefits. Is this in my space to do it? And one thing I always tell our clinicians is sometimes in an intake where I'll ask a patient, have you taken any herbal supplements? I say, have you tried any digital supplements? And usually the patient will, what is a digital supplement, Dr. Torous? And I'll go, well, that could be maybe an app or an online program. And my gosh, once you give people the opportunity to talk about digital things they're using, I would say about half of my patients said, well, yes, I did try X, I did try Y. I didn't realize that was important. I didn't realize you wanted to talk about it and it be in there. So I think by inviting patients to tell you what they've done, you can really learn a lot about what they've tried, why they've tried it. And I think patients are just excited to share what their kind of self-help journey before. So I know I've derailed our conversation from using the tools for prevention. And so I guess I'm saying we could, again, even outside of psychiatry, in primary care in schools,
Sure.
think about smart ways to integrate them. There has been some research, large studies from the UK actually saying, well, if we did school-based mindfulness, did it make a difference? It didn't seem to make a difference. And that's curious to me of what happened. We're still learning, but I think certainly in a healthcare setting, perhaps encouraging these lifestyle factors that we know can be so helpful and using technology to make it easier and to hold people accountable seems like a great step forward, at least for prevention. If we think more about treatment and how these apps could be used in treatment, it does get back to that integration question, where the clinician or whoever's treating has to be comfortable recommending an app, talking about technology, and following up on it. It has to be part of the treatment plan of what we're doing. And to at least get that started at Beth Israel Deaconess Medical Center, we made a clinic called the Digital Clinic. As you can tell, naming things is not our strength, but we said, well, it's going to be called the Digital Clinic, and it's going to be a short-term therapy-focused clinic. And we said, we're open to take almost every patient in our healthcare system. And we said, we're going to give you standard of care, face-to-face, or telehealth now formerly, therapy. But we said, what we want you to do outside of sessions is use an app to monitor your symptoms so we can understand your progress, right? This would be measurement-based care. Because we want to understand how you're doing, and we want you to do your therapy homework on the app, because therapy is only as effective as you practice those skills outside of the session. It's almost like going to a physical therapist. If you don't do the homework exercises, it doesn't work. So what a digital clinic does is it has patients monitor themselves outside the session and has them collect data on their phone about their recovery, where they're doing well, where they're not doing well. But we actually designed a clinic in the clinical workflow. So it's a critical part of each session is we review people's progress and we do it in a non-judgmental way. We say, look, the ground source of truth is still you as the patient. It's what you tell us.
Mhm.
But let's quickly look at how your data was and let's look at how your homework was. And if you weren't able to do it, that's fine. We'll problem solve around that. If you were, does this digital data represent you? Does it give us any clues of where to go? And generally, patients really like that because they get feedback. And so much sometimes of mental health and psychiatry can be intangible, right? You know you're not feeling well, you're feeling down or anxious. But sometimes when you can kind of look at it, you can say, here's how it's changing. It's different at home, it's different on weekdays, it's different in the evening. It really kind of helps
Sure.
strengthen the alliance, I would say, between the clinician and the patient. It almost opens up a new channel for better communication and for better personalization of care. So it's not that the app is driving care. In this clinic, we're not running AI. The app isn't saying you should do this. It's not saying I'm predicting medicine. It's just really saying, let's have a more holistic picture of how you're doing for yourself as the patient and the clinician. And I think that's been just a wonderful experience we've seen in this digital clinic. Again, we probably should find a new name for it, but I think it really has helped patients, I think, maximize their therapy journey in a short term. And what's nice about a short term clinic is we don't have a long wait list. We actually have no wait list. We can bring people in quickly, help them get better. Of course, not everyone gets better, but for a short term clinic, we can refer them to a longer term clinic. But I think
Mhm.
something like a digital clinic is a really good front door for mental health services. And to use some jargony terms, it's kind of what we would call hybrid or blended care, right? So we're not saying just use an app, which would be asynchronous telehealth. You do it on your own. We're not saying it's all synchronous where you're always working with a provider because we don't have enough. We're saying let's take the best of both synchronous telehealth and asynchronous telehealth into these blended or hybrid care models. And I do think that is where mental health is going. If I had to put my money on the table and say in 5 or 10 years, how could we not do these blended care models?
Sure.
Because we get the best of synchronous and asynchronous, and we're doing it and it works really well already.
That's great. And that then leads to the topic of regulation and the role of government agencies such as the FDA in oversight. And the FDA is now in the initial stages of defining standards for digital mental health tools, but regulations and standards for AI in healthcare are still being established and considered. From your perspective, what would you like to see as far as regulations for these technologies, and how far are we from establishing these types of guardrails?
Yeah, it's a hot topic regulation, and I think what's different than anything else before, right, is that these things keep evolving and changing. Apps keep changing. AI by definition keeps changing and learning. So really, it's how do we have regulations that keep up with things that are dynamic and switching. And I also say no country in the world has figured this out. I think it's perhaps it's a global health problem that regulators everywhere have had questions. We've talked with regulators in the UK, in Australia, Germany, definitely the US also looking at it. And what's an interesting kind of piece right to a couple years ago, the FDA had a new model called the pre-certification model. And the idea of the pre-certification model was that it would kind of be a dynamic system where your app would relatively quickly get approved, but based on real world data, performance, and safety, that approval would be kind of canceled or renewed. It ended in September of 2022. The FDA kind of abandoned that pilot project. And I like to joke, they put in their letter, they said, we're going to ask Congress for help. Congress will solve this for us. And without being political, I don't think you go to Congress to solve your digital mental health issue. But I think, and I don't have insider knowledge, but I think it's just the real world data wasn't available to make that pre-cert model work. And I think any regulation, right, you need to have transparent, and you are going to need that real world data. You can't regulate real world systems without real world data. And I think that's why we've seen these health regulators struggle, is because this is not a drug that gets updated every 10 years and does these pivotal studies. What's been also tricky now is a lot of these digital therapeutics is the word they use. The FDA does not really use the word digital therapeutics. They use, I think, digital health technologies, DHTs. So it's interesting, but this word digital therapeutics was kind of built by industry, and they kind of tried to build their own language around it. Say this is a prescription digital therapeutic, this one is a digital therapeutic. They never could quite define what they were. But what's interesting is they kind of said we want to be regulated as medical devices, not as medications. And the regulations for medical devices are, frankly, from my interpretation, a lot looser than, say, for building a new drug, if we set out to do it. And the regulation for medical devices has a lot of, not loopholes, but ways that you can certainly get things approved that are easier. And you're still following all of the rules. But I'm not sure, at least, that the medical devices are the right classification for AI systems, because they're not acting like a walker or a stent that you put in someone's heart rate. These are very different beasts than a device. They are kind of closer to a drug in some ways. But the third part of this, we talked about just we need real world data. We need to classify in the right way is if I give a patient an antidepressant and they swallow it in this analogy, the circulatory system is going to get that drug to the brain. I have some idea they're going to get an effective dose. With these digital tools, as we talk about, we don't know if I get on someone's phone, are they actually going to get that right dose and exposure? The circulatory system does not exist. So I think in the regulatory where we have to take into account, is it something people can actually do? Is it actually be effective? It's not only in a small study where a research assistant tells you to do it and you volunteer to do it. Is that enough? Or do we have to say, hey, the whole reason we're talking about digital is you can be scalable, you can be global, you're affordable. You probably need to prove to us that you really meet that potential in the real world, because if it's so hard to use it, or the study was so artificial, it may not actually be realistic to do it. And I think a lot of these apps, as we talked about earlier, you can get yourself an FDA clearance, but the engagement may be zero, right? So the effective dose people may be getting could be very low. And I think we should also, in some ways, that would encourage companies and developers to build things that are more engaging. Like we can solve this issue. Silicon Valley has built technologies that are very sticky. I'm sure we can build health technologies that are equally sticky.
John, you've underscored just how much potential there is for AI to transform mental health care. A question that always comes up in conversations about AI is to what extent we can expect these technologies to replace what humans do. So I want to ask, looking into the future, do you think AI-powered tools will one day become sophisticated enough to be fully autonomous or to replace psychotherapy?
I think one of my mentors at Beth is called Warner Slack, one of the pioneers in kind of medical informatics. And he had a quote that said, any physician who can be replaced by a computer should be. But really, again, the corollary was that any computer working with a physician is far greater than a computer itself. And I think that same corollary happens. I think we're going to see that the AI things will probably have useful conversations with people. They may be able to help some people. They may be wonderful self-help tools. I think we'll probably see that therapists, psychiatrists, different healthcare professionals begin to use the tools to kind of augment therapy or offer more scalable therapy. But in talking of a lot of patients and professionals, people really don't want to talk to a computer alone about their problems. Oftentimes they'll say, look, John, I spend all my time on a computer. This is probably half the source of my problem is technology. Now you're telling me it's going to fix what I'm doing. So I think I'm excited where these things are going. I think that I've seen, and I think the rest of us will see too, that they're much more powerful used in conjunction with a person. And I think that evidence will be so clear and stark that's where we'll move to. Because again, we've had the internet for a long time, right? It hasn't replaced psychiatrists or therapists. We've had apps now for 15 years, some of them. I think the VA has an app called PTSD Coach, and that's been around since 2011 if you look at the Apple Store. And that hasn't, again, replaced, say, the need for people doing PTSD or exposure therapy. So I think there's always a fear sometimes in the field that a new innovation means that there's a complete change of guard. But I think it more means that we should quickly this time, we may have not found a way to synergistically use apps. Maybe we can learn from those prior mistakes to synergistically use AI.
John, thank you so much for this wonderful conversation. I've certainly learned a lot from it. On my podcast, I always end with two questions that I ask all my guests, and for all our conversations on AI, I'm adding a bit of a twist to those questions. First, what do you think are the most important qualities for a leader, both today and going forward, as we increasingly integrate AI into our professional and personal lives?
That's a hard question, but I think if I had to pick, I'd say there's kind of four things I would want to see. One is, and I'll go over, being hands-on,
Yep.
flexible, but rigorous, and I'll explain that, and really open to collaboration. And I think the hands-on happens because these are new systems evolving, right? It's not enough to claim to be a thought leader in the space. You have to actually play with it and do it because these systems transform
Sure.
every 6 months, if not every year. So I think someone having some experiences in the trenches of these technologies is really useful, I think, for healthcare leaders. I think being flexible matters because you may commit as a leader to a technology and approach, and I might say generative AI comes out. And you do kind of have to be able to say, what's going to be new in 2025 and 2026? You have to be able to switch to some degree, but I think you need to be rigorous at the same time and not say, here's a new technology, let's go with it. I think it's okay to ask the hard questions, say, what is the safety record of it? What is the real evidence? Have you compared it to a control group? You got FDA clearance. What was your real data behind it, right? I think the real leader has to kind of say, evidence is still evidence, right? You can prove to us you're rigorous. There's no exceptionalism. You don't get a pass because you're technology. And so I think you can be flexible enough to switch when you need to, but rigorous enough to keep the course. And then I do think to work in this space, a leader has to be open to collaborations with different departments, right? Say our
Sure.
colleagues in computer science and electrical engineering may not have been our best friends in the past. Now we should work more with them. I'm biased again with my background, but our colleagues in design are going to be incredibly important for building systems that are more engaging. So I think that puts a lot of work on a future leader, right? Because you have to be hands-on, flexible, but rigorous, and a little bit more collaborative, say, than we used to be. So I don't think it's easy to be a leader in this space, but it's important.
And my second question is, what gives you hope for the future?
Yeah, I think what gives me hope for the future, right, especially as a psychiatrist, is psychiatry, right, has not traditionally been the place where we have all this innovation happen, right? We've classically been the field where we've had some new drugs made in the 80s and we've had some additions, but now psychiatry is at the forefront of all these new technologies, and that's really exciting and hopeful, right? We're going to not get it right all the time. We have to be careful. I think the mantra of do no harm is very powerful. It can actually guide us in what to do. But we've talked about new things for prevention, for diagnosis, for management, for these illnesses when, again, in the past, we would not be looking at psychiatry to be doing it. So I
Yeah.
think if we can begin, keep up to speed, again, do it in a rigorous, safe, ethical way, we're going to transform mental health and psychiatry.
Well, John, thank you so much for speaking with me. This has been a really inspiring and informative conversation. And thank you for listening to the Minor Consult with me, Stanford School of Medicine Dean Lloyd Minor. I hope you enjoyed today's discussion with Dr. John Torous, Director of Digital Psychiatry at Beth Israel Deaconess Medical Center. Please send your questions by email to theminorconsult@theminorconsult.com and check out our website, theminorconsult.com, for updates, episodes, and more. To get the latest episodes of The Minor Consult, subscribe on Apple Podcasts, Spotify, or wherever you listen. And if you enjoyed today's episode, please rate the podcast 5 stars. Your feedback helps make this podcast happen. Thank you so much for joining me today. I look forward to our next episode. Until then, stay safe, stay well, and be kind.